It is indeed a very warm afternoon. So we want to welcome you to Home Nursing Foundation CME on non-motor symptoms of Parkinson's disease. As you know, Home Nursing Foundation have been serving frail and vulnerable homebound patients for the past 47 years by providing home health care services such as home therapy, home medical, and home nursing. We also operate 2 senior care centers, one in Hougang and one in Buangkok, and an active aging center to serve the needs of both the dependent and well seniors in the community, with the aim to improve their function, their health, and well-being. Under the prolific clinical leadership of Dr. Ng Wai Chong, we now have the privilege of organizing continuing professional education series relevant to home and long-term care sectors so that we can raise our capabilities and better care for patients together, helping them to live holistically and empowering them to live joyfully in the community. Recently, we have completed a series in the end-of-life care for frail elders. We've also done a series on functional rehab, dementia, falls, and osteoporosis, and also have a series on complex wounds in the community. These videos on YouTube captured during the CME are available on the QR code link in the slides. We also warmly invite you to save your calendar for 6th of October this year, where we will be holding our second Caregivers Conference at Suntec Convention Center. So the date is 6th of October, and we will be launching our care path on caregiver support in the community and invite all of you, experts, practitioners, and caregivers to share your perspective and experiences and network there. This afternoon, we are very privileged and looking forward to Dr. Gwen, who will be sharing her knowledge with us on non-motor symptoms of Parkinson's and the treatment in the community. I'll now pass the time to Dr. Ng Wai Chong to introduce her. Thank you.
Thanks, Christina. So it's my great pleasure to introduce Dr. Gwen Chan. You've already seen her CVs, but just like to highlight that she is specialist in neuropsychiatry. She is a senior consultant psychiatrist in Tan Tock Seng Hospital, and she's director of CLIMB, C-L-I-M-B, which is a center for screening and coordination of the screening and intervention of the various neuropsychiatric disorders. And today she'll be touching on one of such very common issues that we face in the community, people with Parkinson's, and there are non-motor symptoms. So we'll have Dr. Chan to give us a lecture, and at the end of it, as usual, we have about maybe 5 to 10 minutes for Q&A. So if you have any questions, you can type onto the Q&A part of the Zoom. So Dr. Chan, please.
Thank you so much for that very kind introduction, and thank you for inviting me to be here today. So just check I can share my slides now, right? Perfect. Okay. I'm just trying to put it in the presentation mode. Okay, yes, all right, we can start. Okay, so before we start off, maybe I thought I just want to have a sense of the ground and what your current level of knowledge is. So I very much like for all of you to participate in this poll to indicate what is your current level of knowledge about this topic. So the first option is, I really do not know much about non-motor symptoms of Parkinson's disease. Or number 2, I know a little bit. I have patients who probably suffer from them, but I'm not quite sure if I'm right about it. The third option is, I know about non-motor symptoms of Parkinson's, and I think I can confidently identify them in my patients. And while you are participating in this poll, I'll explain to you why, as a psychiatrist, I'm here giving this talk instead of a neurologist. So some of you might be wondering, why are you not hearing from a neurologist or a movement disorders specialist, but you're hearing from a psychiatrist? Okay, so while I don't claim to be an expert on this topic, when I started to see more and more Parkinson's patients in my practice, and specifically actually helping to assess and manage the psychiatric non-motor symptoms of Parkinson's disease, I found that I had to be knowledgeable and very mindful of all the other non-motor symptoms, so that it will be helpful for me in my formulation, my diagnosis and my differential diagnosis, as well as also planning treatment, because sometimes my psychiatric treatments can actually interfere with the other non-psychiatric, non-motor symptoms of Parkinson's disease. And that's how I ended up reading up, learning from my patients and knowing a bit more about the whole spectrum of non-motor symptoms of Parkinson's disease. And that's probably why I'm here today. But again, if there are any questions from today that I don't feel like I'm the expert to answer, I will bring it back to my neurology colleagues and get back to you. Okay, and that much I can do. So thank you very much for participating in this poll. And I think that we now see the results. So about a third, about 30%, really are starting from ground zero. You don't know about this topic at all. About 2/3 know a little bit, right? But not too much. And then slightly about 9-10% are quite confident about identifying non-motor symptoms in Parkinson's patients. Okay. So let's start then from the very basic. Okay. So I'm going to close this one. Okay. So I think we are all very familiar with the motor or the physical symptoms of Parkinson's disease, right? You'll be familiar with patients who are very slow. They might have some resting tremor, so their hands might be shaking. They might appear very stiff. They blink less often than usual, and they're unstable on their feet, right? So these are what we call the common motor symptoms of Parkinson's disease. In fact, the diagnosis of Parkinson's itself is based on these motor symptoms. Some of you might actually have heard that way before a diagnosis of Parkinson's can be confidently made based on the motor symptoms, there can be some non-motor symptoms that happen quite early on, like a prodrome sort of manifestation. And some of these symptoms can include like anosmia, which is the loss of your sense of smell, constipation, and some other GI problems, sleep disorders like REM sleep behavior disorders. So these can happen like years before even the resting tremor or the slowness or the rigidity even sets in. So basically, if you talk to a patient with Parkinson's disease, you might have an idea, you might get this picture that, you know, Parkinson's is really like an iceberg. So the thing that you can see on the outside of the Parkinson's patient are the movement things, right? The shaking, the stiffness, the instability, the falling down, and the slowness. Those are the things that you can see and you can pick up very quickly. But really, that's just the tip of the iceberg, because below the water is where the bulk of the iceberg lies. And in that bulk is really a whole host of these other non-motor symptoms that affect various other systems and parts of the body. And when you look at this, it can seem a little bit overwhelming for you, but we will unpack that in a more organized way later. But first, for this first part of the talk, let's talk about how important non-motor symptoms are in the management of a person with Parkinson's disease. Okay, so this study is really just a very simple survey performed by the Parkinson's Disease Alliance. It was a survey among Parkinson's patients as well as their carers. It included only 17 questions. And they found that actually 90% of the respondents reported having encountered some amount of non-motor symptom. Okay, and these included sleeping problems, cognitive problems, psychiatric problems. And interestingly, it seemed that actually carers were more likely than patients themselves to report these non-motor symptoms, and also to report that the non-motor symptoms are actually more challenging to care for than the motor symptoms themselves. Okay. So what happens in the trajectory of Parkinson's disease? Okay, so this here is a cohort study with 3-year follow-up in a cohort of Chinese patients that were recruited from early stage of PD. And in summary, what they found that during that 3-year follow-up period, there was an increase in the number of non-motor symptoms. And that during these 3 years, they could actually observe worsening of some specific symptoms like sleep, perceptions, psychiatric symptoms, cognitive symptoms, and other GI or urinary symptoms during the period of follow-up. And interestingly, what they found was that the more non-motor symptoms you had in early stage of the disease, that actually predicted faster progression of the motor aspects of the disease. So it seems that the more non-motor symptoms you have from early on, the faster the Parkinson's disease is going to progress as a whole. So we come here to a similar study, which is actually a study of Taiwanese patients that were followed up over 6 years. And it's basically an expansion of what we found from the 3-year study that I mentioned just now. So it found that in 6 years, actually, the trend is that these non-motor symptoms would clearly and significantly become much worse after 6 years. And these individual symptoms actually have their different individual trajectories. Yeah, and the trajectories were actually independent of the PD treatment itself. So you would expect that as Parkinson's progresses, the need for the medications to treat the motor symptoms would get higher and higher. So the doses would tend to increase over the years, right? But the progression of the non-motor symptoms was actually independent of this increase in PD medications over the years. So the largest study that people usually mention when they're talking about non-motor symptoms in Parkinson's is this study called the Priamo study. It was conducted in Europe, in Italy, actually, among 55 sites. It was a multi-center study. And they found that actually almost all of the patients with Parkinson's, 98.6%, which is really almost all of them, reported non-motor symptoms. And the most common being fatigue, anxiety, pain, sleep problems, and cognitive problems as well. And they don't just occur singly. That means when you tend to report a non-motor symptom, it's very likely that you have more than one non-motor symptom. So you have a few or several. And actually, non-motor symptoms in the psychiatric domain was the most frequent. And that's actually why I get a lot of referrals for patients with Parkinson's. And this the number of symptoms actually increases the longer that you have Parkinson's disease and the more severe the Parkinson's disease is. And actually, it is the presence of the psychiatric and cognitive non-motor symptoms that impact their quality of life the most among all the other non-motor symptoms. So how about in our local setting? Okay, in our local setting, this is a study conducted locally among local Parkinson's disease patients that were followed up for 2 years. And what you can see here is that, sorry, let me just have a look. The bar is blocking my slide. Okay, let's see. Okay, is that overall, it is the burden of non-motor symptoms that affect the quality of life more so than the motor symptoms itself. So it seems that whatever was found in other populations is relevant to our local Parkinson's population as well. Okay, so that was just really the basics of non-motor symptoms and how important they are in the management of Parkinson's disease. So I'd like all of us to take part in this MCQ. Okay, so let's identify which of the following statements is false. So if you mouse over the question, you'll be able to see the full question. So the first one is non-motor symptoms can occur anytime during the course of PD. Number 2, non-motor symptoms are a significant concern in advanced PD. The third one, non-motor symptoms are best identified by caregivers. And 4, non-motor symptoms cause worse quality of life and greater caregiver burden. So which of these statements is false? Okay, so the participation has kind of stopped now. Okay, thank you for all your participation. And we can see here on the screen the results of. Okay, so there is a tie between option number 2 and option number 3. 38% opted for option 2 and also 38% opted for option 3. Okay, so the correct answer is actually option number 3. Okay, so I did say that studies show that caregivers were more often reporting non-motor symptoms than the patients themselves, but that doesn't necessarily mean that they are best identified by caregivers. Okay, so actually non-motor symptoms are still best identified by the healthcare professional, okay, which is all of us. Yeah, when we interact with the patients and when we assess the patients. Okay, all right, thank you very much. I'm just going to close this. Okay, I'm going to carry on now with the next section of the talk. And congratulations to all of you. You just cleared the first level. Okay, so when we go next to talk about the whole range of non-motor symptoms of Parkinson's disease, it'll be helpful to actually sort of group them together in some sort of system or grouping so that it's easier for you to remember, right? And as you can see from the slide here, the big group of non-motor symptoms is actually under the autonomic domain. And I'll put that in different colors. Those symptoms that affect the different systems like the genitourinary system, the GI, gastrointestinal system, as well as even the autonomic nervous system, which affects the blood vessels, the vascular, the blood pressure control, as well as temperature control. The other domain is sleep, which I will also be talking about later. And then a big bulk is actually the neuropsychiatric symptoms. And that is where I come in very often to sort of assess and manage the neuropsychiatric symptoms. And then the last domain is actually sensory and others. So to do with your pain sensation, to do with vision, hearing, smell, and speech and all that, which I will be mentioning a little later. Another way or another group of non-motor symptoms that we will sometimes encounter are actually those that are directly related to the treatment of Parkinson's itself. And these are what we call the dopaminergic drug-induced non-motor symptoms, which are often very behavioral. So there is something called dopamine dysregulation syndrome, where patients take more of the dopamine drugs than they should. And then there's these behavioral issues like the impulse control disorders. And there's also the psychiatric part where there are perceptual abnormalities like hallucinations, illusions, and frank psychosis. And then there's the other aspect where I think you will know that some advanced PD patients actually experience an on and off phenomenon called fluctuations, where they experience that sometimes the effect of the medications wear off after about 1 or 2 hours. So these are the motor fluctuations, and we do see that the non-motor symptoms can sometimes fluctuate with the medication cycle as well. And actually, all the non-motor symptoms can actually fluctuate together with the medication cycle. And then there's the remainder of the other non-motor symptoms, where we talk about dopamine agonist withdrawal and some acute Parkinsonian emergencies. So I'll try and mention some of the more common non-motor symptoms, and these are predominantly non-psychiatric in nature. Okay, so first I'll talk about gastrointestinal, the GI symptoms, and the commonest one is actually constipation. But we also do encounter patients who have decreased GI motility, so they have some amount of gastroparesis, and because of that, it affects their oral intake and their nutritional status, causing malnutrition. And this is actually so common that you can actually find it in about 80 to almost 90% of the cases. And as mentioned before, constipation can even be an early prodromal pre-motor symptom of Parkinson's disease. And some people are actually looking at it as a potential biomarker for Parkinson's disease. So we don't really know the mechanisms that are underlying this, but it can also be a side effect of some of the drugs used to treat Parkinson's itself, and some of the drugs used to treat other disorders. And where I'm concerned that my psychiatric drugs may also be causing constipation or some GI symptoms as well. So therefore, the assessment is sometimes not very easy to tease out which is which. But overall, it can be treated with a variety of laxatives, a high fiber diet, and possibly also sometimes probiotics, and of course, maintaining physical activity. So here we talk about speech and communication, and I'm sure in your experience, you would have encountered some PD patients where the voice has become very soft and weak. And sometimes the speech is even slurred, where they're dysarthric. And mostly this is because there is a gradual worsening of the coordination of the muscles that are involved in producing speech because of the neurodegenerative process. And actually, it is surprisingly common. It is almost 90% of patients will develop this at some point. And because of the softening of the voice and the degeneration of the muscular coordination there, you might find that there are also changes in the tone. So the whole quality, the sound quality that is produced is totally altered. But there's also a cognitive component to speech production as well as communication. So the cognitive component of Parkinson's disease can actually cause speech or communication to be very intermittent. It can be too fast at a certain point, and then suddenly it pauses, and then suddenly it becomes very slow. But because of the cognitive component, you might also sometimes see that patients have problems with finding the right word, remembering the right word, or they can mix up words or use the wrong words, right? So this is the cognitive part of speech and communication that you might encounter in your patients as well. So for this really psychological treatments, pacing with the patient, caregiver approach is very important. So giving the patient enough time to think through and to choose the words. So can't rush them. So the more you rush them, the more anxious they get, and then the worse it gets. And also sometimes exploring non-verbal forms of communication as well, like tablets, communication paper and things like that. Yeah, giving options for them to choose rather than to have them speak in long sentences. The next big part is actually swallowing problems. And as Parkinson's disease progresses, we often encounter polypharmacy, where they need to take many pills and they need to take it many times in a day, right? So when there are swallowing problems, medication intake actually becomes a big problem. And oral intake actually also becomes a big problem. So when you have swallowing problems together with GI motility problems, you can find that the patient's oral intake dramatically reduces, and then their whole nutritional status becomes a problem, because then it leads to frailty and all that. And also it might lead to aspiration pneumonia, which is a major cause of death in Parkinson's disease patients. And it really affects a large proportion of them at some point during the disease. It's often attributed to the slowness, the overall muscular slowness, rigidity, and the progression, the motor progression of the disease. So typically you tend to see it and it becomes a concern in the later stages of the disease, but I'm also not surprised to see it happen sometimes early on in the disease. And actually, earlier on in the disease, it tends to be underreported. So if you don't actively look for it or if you don't ask for it, you may not find it. So patients who actually complain of difficulty eating or loss of appetite, or they have the caregiver reports loss of weight, this is definitely a consideration that you have to remember. So one of the ways in which we mitigate this is really to see the speech therapist to advise on the range of exercises that you can do to strengthen the muscles that are involved. And the other simple thing that they can do also is to time their PD medications appropriately. So the general advice given to PD patients is to take the medications on an empty stomach, which is half an hour before meals, right? So that you have maximal absorption of the medicines. But the other reason also is so that when you have maximal absorption of the medication, then you also put the whole muscular system in the on period, right? So the medication is effective, the muscles are on, and they're able to function better. And then after that, the intake of the meal then becomes easier. Okay, so the next big thing is actually postural hypotension, which is underlying, right, ultimately still due to the neurodegenerative process, which leads to damage of the autonomic nervous system. And unfortunately, we see that sometimes some of the PD treatments themselves can worsen the problem of postural hypotension, and treatment then becomes a little bit difficult to kind of like balance the exact dose of medications that's needed. And you all know that postural hypotension has a huge impact on patients' lives because it can lead to falls. And after it has led to a fall, it can lead to fear of falling or fall phobia. And because of the phobia and avoidance, it leads to limitation of physical activity, loss of their physical independence, overall deconditioning, overall reduced quality of life, and ultimately it might lead to more isolation as well as depression. So this is really quite an important symptom to talk about. And patients who have postural hypotension may complain of a variety of very vague and non-specific symptoms, right? So for example, dizziness, lightheaded, feel a bit light and swaying. They might have pre-syncope. Sometimes they might tell you they have a headache, or they might feel a bit breathless when they're standing up, or they might have some vague chest discomfort. Sometimes they have blurring of vision when they stand up, or they just feel weak and unwell all over. So I won't belabor this point too much on the diagnosis and the evaluation of postural hypotension, but basically it is to rule out all other causes, medication related as well as other systemic causes of postural hypotension, to address those causes. And then finally, by excluding all those things, then it is to decide whether it is a neurogenic cause. That means it is directly due to the neurodegenerative process of Parkinson's disease. Now, the management or the goal of management in PD patients with postural hypotension is that, firstly, we need to remember because of neurodegeneration, we cannot achieve normal tension again, right? So this is something that we have to live with. But really, we want to aim to reduce the symptoms that come along with it, right? So non-pharmacological interventions are always first line. So this is what you can advise the patients and their caregivers. So to avoid quick changes in posture, increase their fluid intake, increasing their salt intake, or wearing compression stockings or abdominal binders. And when they lie down with the head elevated, and physical measures such as when they stand up, they should be crossing their legs and squeezing their hands tightly, and also adjusting the timing of their PD medications to something that is more appropriate for their habits or their lifestyle. So pharmacological interventions, the two main ones that we'll be talking about are the mineral corticoids like fludrocortisone, as well as the alpha-1 agonists like midodrine. So I'll come here to the last aspect, non-psychiatric, which is about pain and genital urinary. So pain is actually quite a complex issue in as a non-motor symptom of Parkinson's, because it can have a variety of underlying etiology. So it could be due to a dystonic posture. That means it is an abnormal posture that has been held in place for a long time. And because of that abnormal posture, they suffer from pain. They can also be musculoskeletal, right? Because of prolonged muscle rigidity and sometimes prolonged freezing as well. So these types of pain are actually amenable to the usual Parkinson's treatments and the medications. But there can also be neuropathic pain, which can be really isolated to the affected nerve or nerve root, but it can also be central pain, right? And the hypothesis behind this is that, the parts of the brain that are involved in pain processing are actually degenerating as well in the process of PD. So therefore, what happens is that there is amplification of the sensory stimuli, leading patients to spontaneously experience pain when the dopamine levels are low. Okay, so it is quite a complex phenomenon. So basically, I would say that such patients might require specialist assessment and management. A few points to note about genital urinary symptoms. And these are often done in collaboration with an experienced urologist. And what I mean by that is a urologist experienced in non-motor symptoms of Parkinson's disease. Because symptoms like urinary urgency or sexual dysfunction may need more careful diagnostic evaluation, particularly because in my experience, sometimes these symptoms like urgency or sexual dysfunction can have a psychiatric overlay. For example, like anxiety or depression, okay? And we need to be careful about that because the pharmacological treatments, like for example, specifically the psychotropic treatments, may cause side effects that either mimic these other non-motor symptoms or may interact with these treatments for the non-motor symptoms, okay? Okay, so we have finished this next part. And we are now at 2:30. Maybe we can all do this multiple choice question to test your understanding. So which of the following is not a non-motor symptom of Parkinson's disease? Is it a soft voice? Is it bleeding per rectum? Is it a sensation of bloating? Or is it bed wetting? Okay, so the number of responses has slowed down by now. So I think we'll just go through the options. A large number of you have actually chosen bleeding per rectum. That is not a non-motor symptom, and you are right. Okay, so there's usually another underlying cause of bleeding per rectum. So rather than it being a direct non-motor symptom of Parkinson's disease, just now we mentioned that softening of the volume of the voice is a non-motor symptom. Sensation of bloating can be a non-motor symptom because of the reduced gastric motility. So it's quite common for them to complain that they feel very distended very easily. Bed wetting can be a non-motor symptom because of the underlying bladder issues like urgency. They're not able to get to the toilet in time. There's bladder irritability. Yeah, so you might actually find that they wet the bed, or there might be a sleep problem, that causes them to also sleep too deeply and therefore wet the bed. Okay, right. Thank you very much for participating. I hope I'm not going too fast for you because I think it's at 2:35. We probably have about 20 or 20 minutes more to go through the last part of the talk. So congratulations, you have just cleared another level in your level of knowledge of non-motor symptoms. Okay, so here we will talk about more about the psychiatric non-motor symptoms. And this is really where I come in very often because I see referrals for these patients. Okay, so here I'm going to talk about a lot of case histories so as to illustrate the point. And you might find that some of the patients in your care might overlap with some of these case histories. So the first case here, we have a 45-year-old male who is a high-functioning professional, married with children. And in the absence of any psychosocial stressor, he developed an episode of major depression where, he had the cardinal symptoms of depression. There were pervasive sadness, slowness of movement, social withdrawal, loss of appetite, loss of weight. Now, he improved with antidepressant treatment, but not quite completely. And over the years, there were attempts to sort of gradually discontinue the medications when he was better. But those attempts failed. And 5 years later, he then developed the motor symptoms of tremor, stiffness, and slowness. And then the neurologist made a diagnosis of Parkinson's disease. So the literature actually tells us that depression can actually precede the motor symptoms of Parkinson's disease in about 30% of Parkinson's patients. And a person with depression has a 2 to 3 times increased risk in being diagnosed with PD later, with an average of a 10-year interval between the first depression episode and the diagnosis of PD based on the motor symptoms. So the depression actually occurs more often in the last few years before the PD diagnosis. And therefore, as psychiatrists, we are actually very mindful and cautious about late life depression. That means somebody who has never been depressed before until their middle age or their late middle age, right? So we're pretty cautious about that group and tend to keep them on follow-up because of this issue. So the level of evidence for this is moderate. It's not very sensitive or specific as a kind of like a biomarker for PD, but caution is required nonetheless. Okay. So the next case scenario we have here is that of a 56-year-old male who is a successful managerial professional, married with children. Wife also having her own successful career. Children are also just starting out in their own careers. And soon after being diagnosed with early Parkinson's, this man could not accept his condition, and his family, out of concern, also began restricting his activities and his movements for fear of falls. So he began to feel a loss of independence, confidence, and loss of self-esteem, and he could not accept help from his family. And through this, he then discovered that actually, we seem to be okay as a family, but actually we're not very close. They don't really know me, they don't really understand me, and I don't really understand them. So he began to feel very despondent, withdrawn, helpless, and hopeless. And he began to wonder whether life was worth living after all, and whether life should actually end earlier. Okay. So depression as a psychological reaction to a catastrophic diagnosis can happen anytime. So it can happen at the point of diagnosis of the illness, it can happen at a point in progression of the disease, or after a fall, even if it was just a minor fall. Okay, because a fall can have a very psychologically traumatizing effect on the patient. So this actually needs to be differentiated from what is a normal adjustment reaction, which really gets better with time, or at least there is a trajectory of getting better with time. It also needs to be differentiated from an existential crisis where people are just searching for a deeper meaning in life and existence. What is their identity? What is their purpose, right? So when there is a very obvious overlay of the pervasive sadness, hopelessness, melancholia, suicidal thoughts, then you'll be concerned about depression happening on top of all these things, right? The existential crisis, questioning and all. So some of the risk factors that we're worried about are people with a certain type of pre-morbid personality, usually the achievement types, the go-getter type A personality. Those who have a prior history of depression or anxiety, those who are more socially isolated, or maybe not socially isolated in the physical sense of the word, but emotionally isolated because the family functioning was not too good to begin with. So this kind of depression can actually present as increased irritability or agitation in some people, but in another group, they can actually present more as a withdrawal and melancholia. And we do need to look out for suicide risk in these patients, both these group of patients. And it usually needs both the medical treatment, the pharmacotherapy, as well as the psychotherapy at the same time. So in the next scenario, we have here a 61-year-old lady, a homemaker with 2 grown working children. And she presented with 6 months of behavioral change, which included loss of appetite and loss of weight, being unable to sleep the whole night, where she would be weepy and she would report many worries. And she's also fallen down several times and was observed to be unsteady on her feet and slow in her movements. Her mood actually improved with the antidepressant treatment, but she continued to have frequent falls. And eventually she was diagnosed to have both Parkinson's and depression at the same time. And she had to receive treatment for both concurrently. And that was really the game changer. And she really improved after that. So here we're talking about depression happening concurrently with the motor symptoms of PD. There is a non-motor symptom of PD. And this occurs in roughly about half of PD patients. And it actually does contribute to progression of the PD as a whole. So depressed patients are actually 11 times more likely to develop freezing of gait after 5 years of PD. And they are also twice more likely to develop dementia as a consequence of PD. And when there is depression, this is usually a clue to the existence of other non-motor symptoms as well. And therefore, it is very, very important to treat this kind of depression. But before we actually initiate treatment, first of all, a very thorough and careful evaluation needs to be done. And I will explain why. Because oftentimes when I start to see patients, I must ask myself, is this truly a depression? Or is there something else that is actually not depression, but looks like depression or makes people believe that it is depression? Okay, so after this, we're going to go through some more case scenarios that illustrates my point of what are the other things that can be mistaken for depression. Okay, so here we have a 55-year-old female. She's quite a well-to-do homemaker, and she used to be very socially active, and she's married with children. After being diagnosed with early Parkinson's, the symptoms were very mild. She consistently reported poor response to the PD medications, such that her social activities were almost completely stopped. And on asking her, she would actually say that she was worried that when interacting with people, they would notice that something was wrong with her and they would laugh at her. And she said that if she ever trembled or if she fell down in public, she would feel extremely humiliated. And so she also said that she now has a stammer whenever she spoke with people. So she would rather avoid and she would rather stay at home so that people won't see. She was certain that her PD symptoms were getting worse and she wanted the best and whatever that's better treatment for it. And even when she was staying at home, she was constantly worried about falling down. Okay. So here we have some overlapping symptoms. Is this predominantly an anxiety problem, or is this predominantly a depression problem, or is there both? Okay. So it can be very hard to tell apart the two sometimes because as you see in the middle section, that there are some of these behavioral manifestations that could go for either anxiety or depression or both, because patients can have excessive worry, they can have cognitive problems, they can be restless and agitated, they can be socially withdrawn, they can have appetite and sleep disturbances. They can also have a vague somatic complaints like chest discomfort, abdominal discomfort, that really can't be explained by anything else. Okay. So, but some of the more obvious symptoms of anxiety could be things like trembling more, performance anxiety. So when they're in a social setting where they feel that they need to perform in front of somebody, the tremor gets worse and the symptoms get more obvious. They can have palpitations, they can have hyperventilation, they break out in sweat. They just generally feel more tensed up and they're hypervigilant for even more symptoms. They might even have a sense of panic and they might even suffer from a panic attack while they're trying to perform some daily function. Whereas for depression, they would tend to complain more of a loss of interest, loss of enjoyment, guilty feelings, feeling worthless, grieving over their loss of function, feeling helpless and hopeless about it, and to the extent of sometimes even feeling suicidal. So how do you then actually recognize anxiety? Okay, so some of the more typical symptoms of anxiety is when there is really obvious avoidance of activity. Okay, usually it's more often the anxiety that leads them to avoid social activities or performing certain functions. If they very often break out in sweat, or they sweat very easily, they have panic attacks, they need frequent reassurance, they're quite impatient, and they tell you that they feel very breathless, or their heart is not functioning well because their heart is beating very fast all the time, they can't sleep. They have cognitive problems and they're indecisive, they're ambivalent, they overthink certain issues and they think catastrophically. So they tend to worry about things that haven't even happened yet, that are just in the hypothetical future. So these are the more obvious anxiety symptoms. So anxiety and phobia actually coexist with depression at least half the time. So panic disorder, generalized anxiety disorder, and social phobia are the most common, and they can happen at any stage of PD, and they may be associated with some motor symptoms, particularly balance deficits, right? And there's an overlay of performance anxiety. But later on in the disease, we can actually see that sometimes it comes on very obviously during the motor fluctuations, during the off periods, because the off feels so uncomfortable, it worsens the anxiety and the panic symptoms. And sometimes there's also an unclear relationship between anxiety symptoms and the Parkinson's medications, because some people actually suffer from some physical side effects where after taking the PD medications, they feel physically very uncomfortable. So we're not sure whether that actually is anxiety related to the dosing. But in terms of pharmacotherapy, it's actually the same as treating for depression. Okay. So the next case we're talking about is going to illustrate the syndrome of apathy. Okay, we have here a 62-year-old male who has had Parkinson's for a few years, a recent increase in the treatment to treat a mild worsening of the motor symptoms. And he lives alone with his wife. They have no children. So wife tells you that he refuses to go and attend the support group meetings, refuses to go to the day center, always full of verbal, empty promises to do housework or to follow YouTube video exercises at home, but he doesn't. And instead, he sits at the couch to watch TV all day, and he can do that until he forgets to shower, forgets to eat, would only go out to buy food if he was starving and his wife was not at home. Okay. So a lot of times the caregiver will tell you, oh, he's very lazy. He doesn't do things for himself, always need me to do for him, right? So to the outside world, it looks as if they're lazy, but actually this is apathy. Apathy, they don't feel and they don't want to feel and they don't care to feel, okay? So it looks a lot like depression as well. And to be honest, there are overlapping symptoms between apathy and depression. And as mentioned just now, depression is really more of a feeling of sadness, melancholia, hopelessness, helplessness, and you come away from interacting with the person feeling sad. But the apathetic person actually feels empty. So there is no emotional reactivity to things that are pleasurable and to things that are uncomfortable. So they don't feel happy, and they also don't feel sad when they're supposed to. And they have this lack of concern, right, for the things that are happening around them. So if you leave them alone for the whole day, they can be very happy sitting there doing nothing. But some of these overlapping symptoms are like psychomotor retardation, less energy, being withdrawn, less enthusiastic. So because of this confusion, it can sometimes be very difficult to differentiate the two because they they can coexist, right? And oftentimes, because there is no specific treatment or no great treatment for apathy, sometimes what I do is I offer treatment for depression first, and as a trial to see whether it helps, right? And if it doesn't help, then we can be very sure that it's apathy, and that would need a specific trial of a type of medication called a stimulant, or it needs some behavioral activity scheduling. And this really relies on the caregiver who can enforce the behavioral schedule, okay, which is a challenge, I must admit. Okay. So here we have a 52-year-old male who is married with children, still driving, and he is on treatment for both depression and Parkinson's. And lately, he has complained of being forgetful and not being able to focus because sometimes his mind suddenly goes blank and he can't really follow the discussions at meetings sometimes. He's also started to get into minor accidents while driving with no major injuries or damages to the car, thankfully. But when he describes the accident to you, it is sometimes not his fault, but he acknowledges that sometimes the accident is due to him experiencing some sudden confusion about the directions or the traffic signals, or a lapse in judgment when a sudden quick decision has to be made. So there's a graph to show you that actually in normal aging, everyone experiences some slight cognitive changes, and that's normal. And these are the lines in green, okay? But there will be a group of us who will experience preclinical cognitive decline. And this is a silent phase where you may not even notice it yourself. And, you know, it's very hard to tell. And this group of them, as they progress, they might actually develop this syndrome called mild cognitive impairment, when you start to be slightly concerned, right? Even though overall they're kind of like functioning quite okay, but occasionally they still need a little bit of assistance. So this is called mild cognitive impairment. Now, a large group of MCI patients will actually continue the trajectory to be MCI, but a group of them will actually then progress even further to the dementia stage where it's severe enough to interfere with their ADLs. Now, we know that both depression and Parkinson's disease can affect cognitive function. Okay, the difference is that cognitive impairment in depression is usually that of not paying attention so well, not registering the information, and slowness, therefore leading to what seems to be forgetfulness. But cognitive impairment that's caused by Parkinson's is actually not so much forgetfulness. It is more often in the visual spatial functioning, as well as the executive functioning, which is really the decision-making and the planning part of cognitive functioning. But don't forget that actually chronic and severe sleep deprivation also contributes to cognitive difficulties in both depression and PD, and the treatment strategies will then be very different. Okay, so since we talked about sleep changes, let's talk about this case where the family of a 70-year-old lady with PD has been brought to see the psychiatrist because they think she's depressed. Because she's been refusing to participate in family gatherings because she wants to sleep. And she's been sleeping more in the day than in the night. But in the night, she's not able to fall asleep and she'll often cry in distress. And sometimes when she's taking a long nap in the day, she might suddenly scream and shout and box the air. And once or twice, they thought that they heard her arguing with her late husband over some marital differences. Familiar to you? Okay. So there are a variety of sleep changes that can happen in Parkinson's disease where, firstly, they can sleep too much, they can sleep too little, they can sleep at the wrong times, or they can have abnormal sleep when they sleep, you know, which we're talking about the sleep disorders themselves, like REM sleep disorder, restless leg syndrome. They can also have circadian rhythm problems, right? They can have circadian shift advance or shift delay. And sometimes even medications for other things can also cause effects on sleep. And sometimes their sleep can be disrupted because of PD symptoms that actually occur at night. And the most common of this is actually freezing at night, because when they're frozen in the middle of the night, they can't turn themselves and change their position. And of course, the psychiatric symptoms and the psychological reactions like depression, anxiety can contribute to poor sleep. Insomnia itself can be part of a depression, but insomnia can also be a separate entity altogether. So that is why this part actually needs very, very careful assessment. Okay. So here we have a 68-year-old male PD brought to the hospital because he was sitting on the window ledge contemplating suicide. He said that there was no point in living because his wife is having an affair with a neighbor and the world is coming to an end. And he knows this because every time he hears aircraft flying past his house, tells him that his belief is true. And he's also heard voices telling him to be careful because they're out to harm him and his wife. So the Parkinson's medicines were actually reduced to see whether the hallucinations would improve, but instead the patient suddenly stopped talking, eating, and moving, and he actually had to undergo ECT, electroconvulsive treatment, to get better. So in PD, we sometimes see some severe psychiatric symptoms, right, in the psychosis spectrum. But actually, what we don't often talk about are the milder ones, which are the illusions, which are on the right side of your slide, okay? So illusions are misperception of a real external stimulus. So for example, they might see the curtain, but they might actually misperceive the curtain as a human figure. Okay, so an illusion is different from a hallucination, where a hallucination is a perception without a stimulus. That means they will see insects or animals that are not there, or see humans that are not there. Okay, and then there are the delusions, which are the fixed and false beliefs that cannot be corrected with logic, and they are not consistent with the patient's cultural context. Okay. So these hallucinations and delusions can occur in a very concerning type of depression known as psychotic depression, because if it's untreated, it can progress to catatonia, which is a medical emergency, which is what was described in the case history just now, where the patient stopped talking, eating, and moving. Now, catatonia usually does not respond that well to medications, but responds very well to ECT. But other than this severe form, the psychotic depression, hallucinations and psychotic symptoms can also occur in the absence of depression as a non-motor symptom itself. So we do see Parkinson's disease patients with delusional disorders and patients with benign illusions or hallucinations, particularly benign because they might be a medication side effect, especially when the total daily dose of medications is higher. But when the patient reaches the dementia stage of PDD, then we would respond to the hallucinations and delusions as a behavioral symptom, as a BPSD, where it's not much different from Alzheimer's disease with BPSD. Okay. One of our last case scenarios, we have here a 42-year-old lady, young onset Parkinson's, treated for several years already. Husband reports that she is using her phone excessively, even at the expense of sleeping. She uses it to order food delivery or to play gambling games or to do online shopping. She's eating a lot more, larger portions more often, and she told her husband that she plays the gambling games and does online shopping because it's her coping mechanism, especially when she's stressed by work and she can't sleep at night. But the husband is very concerned, understandably, because she has already spent a lot of money and she has been taking extra doses of her PD medications when she's not supposed to. So we're talking about here of the risk of impulse control disorders, okay? So impulse control means there's not much planning in it. They just think of it and they just do, okay? So particularly concerning if this patient is a young onset PD patient with a long duration of illness, more than 5 years, if they're male with a prior psychiatric history and prior gambling or other behavioral addictions. And also particularly a concern in patients with a high levodopa daily dose a day, or they are on dopamine agonists. So you kind of suspect it when, you know, somebody reports a change in personality or behavior, when there's more secrecy or increased time at work or at hobbies with decreasing need for sleep. And we're starting to take more medication than they're supposed to, and they might even start to hoard their medications. That means they keep and then they take secretly without knowing. So the impulse control disorder is definite when you see that there is compulsive behavior for more than 1 hour a day. And typically it manifests in gambling as well as shopping. They can be binge eating. There can also be hypersexuality, with particularly for males, there might be increased use of pornography. So there's a difference between impulse control and obsessional compulsive disorder, okay? Because OCDs usually have the repetitive and stereotyped element to the picture. Whereas impulse control, for example, if shopping, they will not shop for the same kind of thing, but they will shop for a variety of things. And this may actually overlap with atypical depression, where they use shopping and gambling as maladaptive coping. And treatment for each of these things are different, because usually in impulse control problems, we try to manage them by working with the neurologist to adjust the PD medications. Okay, so we're reaching to the end now. Thank you for staying with me. We have here a 69-year-old lady. The children are all grown and living apart. She's living with her spouse and a helper. She has been on Parkinson's treatment for many years now, and now currently she's on 3-hourly dosing of the medication. So the carers have reported that she has recurring episodes of restlessness where she feels very uncomfortable, can't be satisfied no matter what the husband or the helper does for her. And sometimes the distress can be so severe that she sobs and wails loudly, calls her children at work to come and save her immediately, or even demand for them to call for the ambulance. And on very careful questioning, it seems that these episodes tend to occur about half to 1 hour before the next dose of Madopa is due, and it will somewhat improve about half an hour after the dose of Madopa is taken. And about 1 hour after the dose, she will be back to normal again, and she will then rush to do all the things that she wanted to do. Okay. So this here is a chart that kind of shows you the fluctuations and the consequences of fluctuations in dopamine levels in the brain. So at a certain point of time in the trajectory of the disease, the levels in the brain actually fluctuate quite wildly, and it's quite difficult to reach this very nice window here where there is what we call normal dopaminergic behavior. So when the dopamine levels are just nice, you'll be on, right? It's like switching on the on switch of a machine, and then it can function. But in some cases, you can actually have too much. And motor-wise, you can see that some patients experience dyskinesia, excessive involuntary movements. And in the non-motor side, you can sometimes see, even hypomanic symptoms where they're like overly happy and they're hyperactive and somewhat disinhibited. And when they're off, right, it's like turning a machine off. They can't do anything. Motor-wise, they might be freezing, rigid, very, very slow, and it's a very uncomfortable feeling. So in the non-motor domain, they might actually complain to you about feeling very weak, slow, unable to think. They might even have a panic attack where they think that they're about to die, which is what the scenario showed just now. They might even have suicidal thoughts, right? So this is during the off phase. So non-motor symptoms can also fluctuate, just like motor symptoms can fluctuate. And when this happens, it's actually quite difficult for symptoms to meet the criteria for major depressive disorder, because in major depression, the symptoms need to be pervasive. That means they're there most of the time. But when there's fluctuations, they're not there most of the time. They're clearly there sometimes only. So they may not meet the criteria. And so this is usually managed by working with a neurologist to optimize the PD treatment, and sometimes some amount of medications to relieve the panic attacks that might happen, because when they panic, the other non-motor symptoms might actually get worse as well. Okay, so thank you. We have reached the end of the talk. So can we have this final multiple choice question? Which of the following cannot be confidently diagnosed with corroborative history from appropriate caregivers in the home or residential care setting? Is it a REM sleep behavior disorder? Is it apathy? Is it panic attacks during off periods? Or is it dementia? Okay, so the responses have kind of slowed down and coming in now. So let's take a look at the options. So 27% have opted for REM sleep behavior disorder, 32% have opted for apathy, 22% have opted for panic attacks during the off periods, and 34% have opted for dementia. Okay, and in my mind, the correct answer is actually dementia. Okay, because in dementia, actually what would really confirm or sort of add more weight to the diagnosis is actually objective cognitive testing. Yeah, so corroborative history is helpful, but you do still need the objective cognitive testing to be able to confidently diagnose the dementia. Whereas REM sleep behavior disorder, apathy, panic attacks, if you have a good caregiver who can actually describe to you exactly what the behavior is, I can actually confidently diagnose those things just with corroborative history on its own. Okay, so thank you very much for staying with me until now. Yeah, so now I'm happy to take questions. Thank you very much.
Thank you, Gwen. And it's an excellent talk, very informative. We have many questions. We've got 5 at the moment. Let's try to finish them all because I think they are quite good. Dr. Siu asked about differentiating between adjustment reactions and grief. You mentioned adjustment reaction could be one of the reasons for people with dementia, Parkinson's. How do you differentiate?
Yeah. So this is where actually a very careful assessment, I think also being mindful of the stage of disease, of Parkinson's disease, firstly, how severe it is, also the psychosocial setup and the psychological state of the patient. And it really involves extended interviews, right? So we really need to spend the time to talk to the patient, drill down the psychopathology, also a corroborative history about the functioning and whether there have been any changes in the level of functioning for the patient, how these reported symptoms have interfered with how they manage daily life. So generally in adjustment reactions and existential crisis, we don't expect too much functional impairment. Yeah. Whereas when there's an overlay of major depression, the functional impairment will be more obvious. Yeah. So complicated grief and adjustment reactions. So adjustment reactions, usually we're looking at a trajectory of improvement. That means with time, as you follow up with the patient, you should see that there is a direction that it is getting better. But if it doesn't and it stays stagnant and not improving for more than 6 months, then you'll be worried that it is not just an adjustment reaction. So the duration of symptoms is also important. The trajectory is also important. Complicated grief also. Again, on extended interview, drilling down the psychopathology, to see how they perceive or they understand and actually process their own symptoms, whether they're developing more insight about their own emotional state and how they're adapting to the diagnosis. So those are all important things that I would look at in actually trying to tell the difference. Yeah, it is not easy, and sometimes you can't do it immediately on the first visit. And definitely I will need to get to know the patient better over subsequent visits and talk more before I can actually confidently tell the difference.
Thank you. The second question is about the difference between Lewy body disease and Parkinson's disease, as both can have mood and anxiety and psychosis as early symptoms. How did you differentiate between Lewy body disease and Parkinson's disease?
Yeah, great question. So actually, with Lewy body disease, generally the criteria is that there should be significant cognitive impairment from the onset of symptoms. Yeah. Whereas in PD, cognitive impairment or cognitive symptoms are actually not part of the diagnostic criteria for Parkinson's disease. Yeah, and also the trajectory and the chronology of symptom development as well. So you would expect that the dementia and the cognitive impairment actually starts to develop and deteriorate later on in the trajectory of Parkinson's disease, generally after a few years. But it tends to develop earlier and decline earlier in Lewy body from the onset of symptoms.
Thank you. The third question is about, you mentioned for treatment of apathy, you can try with antidepressants. So what specific kind of medication would you use for apathy?
Yeah. Okay, so there are many considerations here. So it really depends also on the formulation, right? How likely you think there is an underlying depression. If I think that there's a coexisting depression, then I would still go for SSRIs as the first line. But if I'm actually thinking that there is a lot more anhedonia, loss of energy, I might try actually a more dopaminergic antidepressant like Wellbutrin. But if I'm very clear that it's apathy, it's not depression, then I would offer a trial of stimulant, methylphenidate. Yeah.
Okay, thanks. So Bilin asks, are there any anti-anxiety or antidepressants known to increase the risk of PD or exacerbate the symptoms of PD?
Okay, not increasing the risk of PD, but sometimes in the SSRIs, the serotonergic antidepressants, some patients might actually complain of very mild hand tremors. Yeah. But because it's a serotonergic effect. Yeah. But usually, clinically, you can tell the difference between a serotonergic effect and a PD tremor.
Oh.
Yeah. Yeah. So in that sense, I don't think that it will exacerbate the motor symptoms of PD in that sense. Yeah. If anything, what I've seen more often is actually untreated anxiety, making the tremors worse because of performance anxiety.
Okay, the fifth question is related to, I suppose, non-pharmacological strategies to deal with apathy. And any other ways to deal with apathy apart from medication?
Yeah. So generally, when it comes to these psychiatric non-motor symptoms, actually goal setting is actually very important. Goal setting collaboratively with the patient themselves and also the carer themselves, because this helps to moderate expectations for everyone. Yeah. Right. So moderation of expectations is actually very important because, you may want to say, you may not want the patient to have a schedule every day of the week from Monday to Sunday. How about we try once or twice a week first? Right? Yeah. And then we work slowly from there. Yeah. So it's really a collaborative approach, so that, the caregiver also doesn't need to, chiong all the resources, on this very high expectation of putting in activities every day of the week.
Yeah.
Yeah. So those are some of the non-pharm strategies that we use to work with patients and their families.
Setting goals and manage expectations. Thank you. Dr. Ron asked about the choice of antipsychotic for psychosis in PD.
Yeah. Okay, so if you look at the British guidelines for this, they actually recommend clozapine. Yeah. They use clozapine quite easily for this, but locally it's not very contextual, not very applicable to our context because there are restricted prescribing rights for clozapine. Yeah, so only psychiatrists can prescribe clozapine because of the blood monitoring that's required. Yeah, so they need to do a weekly FBC for the first 16 to 18 weeks, and then after that, monthly FBC for life. Yeah, so we don't tend to use that as first line. So some neurologists that I work with are actually quite confident to start quetiapine, to manage mild hallucinations that are not so severe. But when the hallucinations and the psychosis are persistent and are getting more severe and making it a bit more risky for everybody, that's when they will refer to me because they're not quite confident about the dose range of antipsychotic to go to. Yeah, so that's when I come in. And generally, if quetiapine, the problem is that when it's not so effective at low doses, you might need higher doses, but that's when side effects tend to become a concern, like postural hypotension and sedation, which the PD patient is very sensitive to.
Yeah.
So that's when I would have to consider alternative antipsychotics that are more potent. And then, of course, I've definitely had a handful of patients where really difficult, definitely have to use clozapine already. But clozapine is also not without its problems. Yeah, so this is really a tertiary care sort of problem, a specialist kind of problem. Yeah.
Thank you, Gwen. Actually, we are overrun, but there are a few other questions. I look at them. Many of them are not really related to today's topic, but there's one that may be related. Maybe we'll just answer this as the last one. It's the one by Dr. Yeo Ki Hong. Is the neurochemical deficit in non-motor symptoms that precede PD the same? And then starting pharmacological agent for PD helps with the non-motor symptoms of PD.
Okay. We don't actually know the answer for that at the moment, right? So the hypothesis and the theory is that it is alpha-synuclein deposition. Yeah. And also in specific parts of the brain that start to degenerate earlier than the basal ganglia, the substantia nigra. Yeah. So that's why we don't really have good treatments for treating pre-motor PD, only that you know who are the high-risk ones and who you want to follow up on. And I suppose the question, I understand it correctly, is that whether starting PD pharmacotherapy during the pre-motor stage will help. Okay, this one I'm not very sure. I haven't seen any patients who have been given that treatment for pre-motor PD, but let me double check with my neurology colleagues.
Okay. So I suppose now it's like 15 minutes past our
so sorry
time.
about that.
No, thanks so much. It's your generosity. We really appreciate that. We learned a lot. I learned so much and really updated my own knowledge about non-motor symptoms. So with that, maybe Christina, would you like to have the last word?
I think I just want to take this time to thank Gwen and also to give a shout out for the next month's CME, which is always the first Saturday of that month. And Gwen will also be coming back to present another topic that is commonly encountered in the community. So please keep a lookout for all our notifications via your email. And thanks for spending your afternoon with us.
Okay, thank you.